and now I leave the stage to you. Thank you.
So thank you very much, Professor Stella, and thank you also to all the organizers for inviting me to this special event, and good afternoon to everybody. First of all, I have some disclosure. I have been consultant for a few pharmaceutical companies, but also I have to disclose that, as you can imagine, I have a strong interest and passion for respiratory care of the newborns, but I'm just a beginner in the field of artificial intelligence. However, thanks to this collaboration that we started with Professor Stella, I really realized that this is truly a promising tool, especially in our field. So today, during this talk, I will try to cover the issue related to BPD, what it is, how we define this disease, what are the long-term complications and the main risk factors. Also, we will see what has been done already in terms of application of artificial intelligence to the field of BPD, and we will discuss probably mostly after the talk about the potentials and the challenges of this application to the field of BPD and in general to respiratory care of the newborns. So in this picture, you can see our hospital lighted in purple during November 17. November 17 is internationally recognized as the Prematurity Day. How many babies are born preterm every year? Around 10% of global birth. So this means about 13 million babies per year, with, of course, a little bit of uneven distribution across the different continents. Prematurity matters because it has been recognized by the WHO as the first cause in terms of global burden of disease. Not all the preterm infants are the same. Most of preterm infants are born in the so-called moderate to late preterm period, but the one that numerically are for sure less represented, but that, let's say, absorb the vast majority of our energy and resources are those that are born extremely preterm, because those are also the sickest one. However, in the last few years, thanks to pharmaceutical and also technological improvement, globally, the survival of these infants born at extremely low gestational age, down to 22, 23 weeks of gestation, has globally improved. As you can see, represented in this graph that pulls together the data from the major epidemiological studies that has been done across the globe. Together with an improvement in survival, also the occurrence of all the major complications of prematurity has dropped in the last few decades, with the exception of chronic lung disease or bronchopulmonary dysplasia, which is actually the most frequent chronic respiratory disease of early childhood. And the occurrence of this disorder, for instance, in the United States, among those born below 28 weeks of gestation or below 1.5 kilo, is around 45%. BPD is also one of the major causes of death during the neonatal period, during the NICU stay, as you can see, after the second week of life. But what is really BPD? This is also an issue, as you can see from this figure. We have changed our way of defining the disease across the years. The first time BPD has been described was in 1967 by Northway, and at this time BPD was described as a disease typical of moderate premature neonates that were intubated, mechanically ventilated, and received a high concentration of oxygen. However, over time, the disease feature has changed. So at the beginning, they were characterized by moderate preterm infants with a prevalence of fibrotic process into the lung due to this aggressive ventilation and very high oxygen concentration. Towards the year, we have become much more gentle, but at the same time, as a consequence of an increased survival, also the feature of this disease has changed. And so globally now is more characterized by a simplification in the lung development, and it is now called new BPD. So BPD is a changing disease. It is a disease that has been defined in many different ways. One of the major limitations of all this definition is that they have been mostly based on the respiratory support provided to the baby rather than on physiopathology, meaning that it's like to define that the patient is hypertensive just because he received medication for hypertension. But on the other side, BPD is truly a very complex disease, as you can also imagine from this figure. I won't go too much into detail, but it is caused by many different etiological factors that can interact among themselves in very different ways. And as a consequence, they produce also very different phenotypes of this disease, meaning that BPD is truly a very heterogeneous disease. Just to point out that BPD is not the only respiratory issue of preterm infants. From a very elegant study by Morrow and collaborators, we worked out that about 20% of the infants that are diagnosed with BPD do not present in early childhood respiratory symptoms. By contrast, around 35% of those that are not diagnosed with BPD will later suffer from respiratory disease, meaning that probably we need also to think a little bit different about the outcome that we are considering. So as I previously mentioned, BPD is a multifactorial disease. And due to this, if we want truly to decrease the occurrence of this disease, it means that we need to act on a multitude of factors. And we need also because at the moment, we do not have truly available therapy to cure those infants, we need to put all our efforts in preventive strategies. So what are the main risk factors for BPD? For sure, the most important risk factor for developing BPD is prematurity itself, meaning that those infants are born at the stage of lung development where they have no alveoli. The lungs are completely unprepared to survival. So you would argue that probably the most effective preventive strategy for BPD would be preventing preterm birth. However, we know that this is not always possible, in particular when there are two conditions. One is the inflammation and the infection of the placenta and the amniotic sac, and the other one is the vascular disease of the placenta. This put also the fetus at risk, and so preterm delivery in this case are unavoidable. So for sure, BPD start also antenatally. As mentioned already, there are risk factors that can start damaging and altering the lung development in utero. One for sure is chorioamnionitis. Chorioamnionitis actually can also prime and accelerate at the very beginning of the infection the lung maturation, but meta-analysis demonstrated that on the long term, the inflammation produced by the infection is one of the major risk factors for developing bronchopulmonary dysplasia. On the other hand, another issue that can present during pregnancy is the vascular disease of the placenta, and this through a complex angiogenetic signaling disruption can also alter the vascular development of the fetal lung and also to other organs. And it is well recognized in the literature that infants born to mother with a vascular issue of the placenta has an increased risk of developing BPD, and not only present an altered lung function in early childhood, but they still present altered lung function and obstructive pattern at spirometry in adult life. What we can do to help those infants that are born preterm is to administrate antenatal corticosteroids. Antenatal corticosteroids prevent the risk of respiratory failure at birth, also improve survival, and prevent other complications such as the intraventricular hemorrhage of those infants. However, has not a direct effect in decreasing BPD. So sometimes it's difficult to, let's say, put in place preventive strategy antenatally. what we can do as neonatologists is to put all our efforts to avoid all the potential source of injury after birth, since the delivery room to the NICU stay. First of all, after gestational age, I would say the most important factors to prevent BPD is to avoid invasive mechanical ventilation. And in the latest decades, we truly have started, even in those that are born extremely preterm, our respiratory support through non-invasive form of ventilation. Nowadays, we have developed even more sophisticated form of assistance through non-invasive interfaces, such as NIPPV, that in recent meta-analysis has been demonstrated being more effective than nasal CPAP. This is a study that we conducted together with Kurt Albertin and Marjan Nadal in Utah. They have, those collaborators has developed a very robust model of BPD in preterm lungs. And even for those of you that are not expert in histology, I think that is clear that those lungs that are supported by non-invasive respiratory support present an alveolarization, a lung development, which is much more closer to the term lungs as compared to those who, by contrast, are mechanically ventilated and present a much more simplified pattern in alveolarization and much thicker wall of the alveoli. As mentioned, we were probably able to improve preterm infant survival also thanks to the technological development of technique for ventilation. Nowadays, we have also developed modes of non-invasive ventilation that apply different form of triggers in order to enhance the support to these infants. And I guess that in the next few years you will see, let's say that not for all this technique we have strong evidence that they can prevent BPD, but there are a lot of research going on in order to evaluate if they can decrease the respiratory risk of these infants. Another very important therapy that we administer to our preterm infants in order to support breathing is surfactant. Surfactant is a substance that we all produce and that allow us to keep our lung open. Unfortunately, the very preterm one do not produce or produce an insufficient amount of surfactant. During the last few years, we have developed progressively less and less invasive form to administer surfactant in order to maximize the therapy delivery and minimize the risk associated to mechanical ventilation. And to date, this technique that you can see represented in the slide, less invasive surfactant administration, which consists in administering surfactants through a very thin catheter through the vocal cords while the baby is still breathing spontaneously, is considered the most protective in order to avoid BPD. Another risk factor that is strictly associated to BPD genesis is oxygen administration. We all need oxygen, also the fetus and the neonate need oxygen, but for preterm infants, high concentration of oxygen associated to oxidative stress are dangerous because their organ, particularly the lung and the retina, are particularly vulnerable to this injury. So we performed as neonatologists many different studies. We compared many different range of oxygen saturation, and we convey that intermediate range of oxygen saturation, such as those between 90 and 95%, are the ones that mostly protect our infants both from the risk of hypoxia in terms of death and necrotizing enterocolitis, and avoid also hyperoxia, which associate by contrast to BPD and ROP. Infections also play an important role, similarly to chorioamnionitis, in the pathogenesis of BPD through an inflammatory process. So those infants that present late onset sepsis has an increased risk of developing BPD. At the same time, and this is a more emerging evidence, also the unwise use, the useful exposure to antibiotics by probably a complex mechanism of altering the infant's microbiota has been also associated to the genesis of BPD. More specific therapies, such as the one to prevent the Ureaplasma aureolithicum, which is a specific microorganism associated to BPD, fail to demonstrate benefits in terms of preventive treatment. Also, growth is an essential, play an essential role in the genesis, in the development of BPD. We know that is important also to the lung and not only to the other organs to grow. But feeding preterm infants is also very difficult because they cannot tolerate a huge amount of milk. What do we know now is that comparing different feeding regimen, mother own milk can significantly reduce the risk of BPD, and also later on can improve lung function and avoid obstructive pattern at the lung function testing at 2 years of age. More controversial is the role of specific nutrients such as DHA or postnatal vitamin A. Then coming to drugs and medication to prevent BPD, one of the simplest but more effective one that we have in hands is caffeine. Caffeine has been traditionally given to preterm infants to stimulate their breathing pattern, to stimulate the brain stem. But thanks to the CAP trial, they demonstrate that caffeine given since the first since the first 3 days of life can also prevent BPD, other than having a very positive influence on long-term neurodevelopmental outcome. Another drug that has been used to prevent BPD are the postnatal corticosteroids. As you probably know from different fields of medicine, corticosteroids always associate with a side effect. For preterm infants, those side effects are particularly worrisome because they may affect, they may alter the brain development. So we have tested and tried in trials many different molecules with a very different regimen, different dosing, starting from early life rather than later on. And to date, the most safe molecule seems to be dexamethasone given as a late treatment after 7 days of life. But for sure, this is highly debated in the neonatal field. This is the latest meta-analysis by Lex Doyle from Melbourne, Australia, that still confirm that dexamethasone can be given to the infants when the risk of BPD overweight the risk of brain injury in terms of cerebral palsy. But again, predicting BPD is not always that easy. Finally, speaking about therapy for BPD, all the molecules that you can see listed in this table are the latest discovery that has been already tested in preclinical setting, and in the recent year are being translated to the neonatal ICU, to human studies, but still little evidence, and probably also due to some issue in trial design and in the difficulty to identify truly the target population. And I think that to this aim, artificial intelligence could probably provide us some useful tools. So what are the consequences of BPD? BPD is not only an issue for us as neonatologists, is not only confined to the NICU walls, but it is something that lasts long life, meaning that infants with BPD will present an increased risk of hospitalization in the first 2 years of life. They will present a higher need of inhaled medication and supplemental oxygen. Also, the risk of receiving a tracheostomy is significantly higher, and this, of course, is also secondary, is also strictly associated to the severity of the disease. Infants with BPD will still continue to present respiratory symptoms over time. In the first 2 years, as mentioned, about 50% of the infants with BPD are hospitalized, and they present wheeze, need of inhaled medication, wheezing. They will still present a wheezing pattern in preschooler age, and also during later childhood and adolescence, they will still present wheezing, asthma symptom, exercise-induced respiratory symptom, and the needs for inhaled medication. This is a very elegant study from Shannon Simpson in Perth, Australia, that shows lung function in late childhood, comparing preterm infants with and without BPD. As you can see, those with BPD that are represented by solid line present a higher, a more severe decline in lung function up to 12 years of age, but also those without a diagnosis of BPD present a lung function which is below normality. Even in adulthood, subject with a diagnosis of BPD present respiratory symptoms. They have an increased risk of hospitalization, asthma, and also an earlier decline towards COPD has been described. But also they present adverse neuromotor function and worse academic performance. This graph represents the lung function. Probably the vast majority of us present a lung function that overlap the green line. We have a normal lung function, but the babies that are born preterm never achieve the physiological peak in lung function that we generally achieve around 18 to 20 years of age. We do not know now, to date, if there is the opportunity for those babies to sort of catch up and recover their lung function over time. But what we know for sure from epidemiological study is that they experience an earlier decline in lung function and also in some cases a premature death. And this, for instance, is one of the studies that demonstrate these infants born preterm, of course, also related to the prematurity, present an increased risk of obstructive airways disease, but also a much higher risk of developing chronic obstructive pulmonary disease. So let's see now some example of how artificial intelligence can be applied to the field of neonatology and in particular to the BPD related issues. This is one of the first studies that applied artificial intelligence to the BPD field. Is a study from our colleague from Denmark that aimed to develop an algorithm to predict BPD. They applied, unfortunately, one of the oldest definitions of BPD, the NICHD definition 2001, and they studied infants below 32 weeks of gestation. Which kind of data source they applied to in their study? They used both demographic and clinical data, and also this group particularly is specialized in analyzing the gastric aspirates and through a spectrometry technique in order to detect metabolites of surfactant. In terms of artificial intelligence model, they applied a support vector machine, and they actually studied relatively limited sample size, 61 neonates. Of those, 43% developed BPD, and they found relatively good sensitivity and specificity. However, this study has several flaws. I already mentioned an outdated definition of BPD. They use a small sample size. They lacked an external validation, and also they let's say, applied a sort of static prediction at birth, avoiding and do not considering other factors of epigenetics that can actually be associated to BPD development. This is another study from colleagues from California, United States, who aimed at developing BPD prediction tools by studying both perinatal features, antenatal features, and trajectory of early life respiratory support. They actually studied infants born between 2013 and 2020 with a gestational age below or equal to 30 weeks of gestation. They applied a more recent and updated definition, which is the Jensen definition that actually is considered the one that has the best prognostic power among those that has been used in clinical practice, and they used two different data sets: perinatal variables, including sex, ethnicity, gestational age, birth weight, and maternal smoking during pregnancy, and also the different type of respiratory support applied. They selected about 80% of their data set for training the machine learning algorithm that was a random forest in this case, and 20% for the validation. They use 4 random forest models to train, one considering only the perinatal features, one considering the respiratory support from day one, and another one considering the respiratory support from day 1 to 7, and the fourth model considering the respiratory support from day 1 to 14. And then they combined the different models. Actually, they found already good accuracy performance just using the perinatal features, and these support the hypothesis that we also mentioned during the introduction of the early origin, the early development of BPD in utero. And this has a rationale, meaning that even though some factors such as sex and ethnicity are not modifiable, others such as maternal smoking, that is a very important risk factor for BPD, or gestational age and fetal weight gain can be somehow manipulated by clinician. But did not include other important antenatal variables such as choramnionitis and preeclampsia. However, they also found that the model that combined both perinatal and respiratory support is the one that has the best predictive accuracy. Limitation of these studies were that it was only a single center study. They only perform a binary prediction of BPD, but as I mentioned during the introduction, this is really a very heterogeneous disease with a very wide variation in clinical presentation. And also in this model, which was still a very elegant and nice study, they mostly focus on respiratory care. But as we mentioned, there are also some other factors that can significantly affect the genesis of this disease. This is another study from Korea. They aimed at developing a predictive tool considering the severity of the disease. And they were considering both prenatal and early postnatal variable. They were having access to data from a very large registry, the Korean Neonatal Network Registry, and they were including infants with a birth weight below 1.5 kilo. They also enrolled a relatively recent cohort of infants between 2013 and 2020, and they selected 45 perinatal variables from their study. They also applied the old definition of the NICHD 2001. As an artificial intelligence model, they applied a MLP-based network analysis. Actually, they had a very large sample size, more than 11,000 infants. Of those, 33% had no BPD, about 70% developed BPD. Additionally, they applied also a complementary MLP network to establish a new BPD prediction models. They found that their machine learning, their models outperformed as compared to the standard machine learning approaches for both binary prediction and severity prediction of BPD. And they also applied a Shapley method to identify the contribution of each variable. For example, they found that gestational age, birth weight, and patent ductus arteriosus treatment were significantly associated to the occurrence of BPD, whereas birth weight, gestational age, and pulmonary hypertension were the most significant variable associated to the severity in very low bore weight infants. This study, of course, had some pros. They use a very large cohort. They applied a new model of machine learning. They had the advantages of making a severity prediction of the disease, and also the attempt at identifying the contribution of the single variable of each model. However, in this study, they used static data with no temporal evolution. They didn't include biomarker, clinical symptoms, vital signs, and other, for instance, radiological findings. They applied an old definition, and also some of their findings were difficult to be interpreted. To date, we have seen a study applying mostly demographic and perinatal variable or respiratory support variable, but artificial intelligence has been applied also, for instance, to the genetic field. In this study, they performed the exosome to all the infants born below 32 weeks of gestation with a sample size of 245 infants. And in this case, they were able to identify through the application of artificial intelligence the most significant genetic mutation associated to the genesis of BPD. And they also studied a predictive model where adding the genetic variants to the standard demographic and perinatal variable improved the prediction power of the model. Artificial intelligence has been applied also to lung imaging to predict BPD, such as in these studies that, however, present some bias, mostly due to the fact that the authors compared the performance of their machine learning approach to the judgment of the expert, that for sure is a bit subjective. I'm now briefly presenting a few details about a pilot study that we performed thanks to the collaboration with Professor Stella and his PhD student Federico Pirola and the student Carlotta Bellomo, and also my colleague Giacomo Cavallaro. We aimed at looking if the temporal data collected in the first 2 weeks of life can improve the accuracy in the BPD prediction as compared to the data available at birth. And in this study, we included our infants below 32 weeks of gestation and below 1.5 kilo. We only included inborn infants in order to avoid a large portion of missing data. And we studied a recent cohort of infants between 2017 and 2022. We, of course, excluded infants with congenital malformation, the outborn, or those who died during the study period. The outcome for us was also defined by the most recent definition by Jensen. We selected 461 babies. Of those, about 35% developed BPD according to the Jensen definition. Of course, if we consider only the very immature one, the occurrence of BPD was much higher, almost doubled. Which kind of information of data we studied? We included demographic data, respiratory support, and respiratory support parameters such as the oxygen requirement, the pressure provided. We included vital parameters, blood test, medication, and also data related to feeding and weight. And we created 2 data sets, one continuous and one discretized. As artificial intelligence model, we applied random forest and XGBoost for the experiment, using 70% of the data for training and 30% for testing. We perform imputation of missing value, and hyperparameters optimization based on F1. And these are some of our results. For the discretized data, we found an improvement in the accuracy measure from day 1 to day 14, and a better accuracy by consider the whole time period. Okay. Oh. For the continuous data, we found even a better accuracy measure by considering the continuous data. So we were able to make an early diagnosis by applying this model to our data. One of the novelty of our study is that we use daily data, and we also introduced variables that were not applied in other studies. Interestingly, we found especially the respiratory parameters and the indices of growth and nutrition for predicting BPD, and we found that our model was more performant in healthy neonate with a higher specificity than in those with BPD. It was very important for us to interact among that data scientists and clinicians because, for instance, we found out from the study that caffeine was not such an important feature, but this is because due to the evidence, we truly provide caffeine to all those infants at risk of BPD. And we are also planning to continue our collaboration by investigating a bit further a causal model of BPD. We need also to provide an external validation of this model, and also our dream would be to extend our collaboration in order to with the aim of disease prevention and also making a treatment effect estimation. This is a recent review about the application of artificial intelligence to the BPD field that well synthesize the different data sources that have been used, the different machine learning technique, model for evaluation metrics, and the different applications. For sure, the application of artificial intelligence to BPD present different challenges and limitations. One for sure, and we truly realized by conducting this first trial, is the data gaps. Data are collected maybe incompletely. Sometimes there are errors in the data collection. And there could be also a data collection bias, for instance, when a population is unrepresented in the data set. For sure, there are issues in real-time data integration, and these are due to very heterogeneous data, high volume, high velocity data, different platform for data sources, also delay in the availability of data, such as those that comes from long biological analysis. And also there are issues about data privacy and security. Very often, the model provided are complex in terms of interpretation, are like black boxes that are then difficult to be interpreted by clinicians, and also there could be an overfitting issue that produce noises into the system. Other issue can be data bias, misuse risk. Also, another issue for us as clinicians is trust, especially when the algorithm is oriented to some important medical decision. And again, problems about regulatory institution, ethical concerns, resources, and also constraints. For sure, opportunities and future direction are enhancing the model interpretability. And this for sure can be done by a strict collaboration between data scientists and clinicians. We need to expand the access to data, which is not always that easy, and also addressing bias. And also we probably need a reciprocal workforce training, and for sure enhancing our interdisciplinarity. So in conclusion, BPD still represents a big issue for preterm infants. Is a disease with a high incidence and a high burden of disease and high cost for the healthcare system. It is a multifactorial disease and no therapy exists, meaning that an accurate and an early prediction are essential for putting in place a proper preventive plan. A BPD model has been developed, but to date they are not really widespread in our neonatal community. And also the model that has been applied still presents some methodological flaws, such as small sample size, lack of external validation, increased bias, and a lot of them lack of dynamism. Given the multifold nature of BPD, for sure, artificial intelligence could help us further in order to assess causal relationship and eventually highlight fields and etiology that hasn't been properly investigated. But also, I think that artificial intelligence has a role in identifying and differentiating the different population within this heterogeneous disease and assisting us in providing a more targeted and personalized treatment. For all these issues, for sure, again, collaboration among the different scientists is essential. So I want to thank Professor Stella very much for this opportunity, my colleague Giacomo Cavallaro, my collaborators, the students that did truly a fabulous job. And above all, I want to thank our little patient, in particular, those two little ones that are my superhero of 2024. And as all our baby, they always teach us really a lot. Thank you very much.
Thank you very much, Anna. A very nice presentation. Really.